A very warm welcome to the ISA Online PG classes. These classes are held every Monday evening at 6:30 p.m. and is an initiative by the ISA leadership, which is of immense benefit to all the postgraduates and faculty from all over the country spare their valuable time and effort. And today is no different. But before we start the classes, as is customary, we start with the invoking of the blessings of Mata Saraswati. So
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा.
So to begin the class today, we have our Secretary ISA National, Dr. Sukhminderjeet Singh Bajwa sir, who will introduce these classes in general. And today we have an innovative class, and he'll introduce the class in particular today. Dr. Sukhminderjeet Singh sir, please.
अरे डॉक्टर नवीन का नाम ले लिया, लेने दे, ले लो भैया. अरे नवीन भाई पहले बोल लो, आज आप लास्ट डे बोलने का क्लास से पहले.
No. Please let the academics flow. Thank you.
Yeah. Okay. Welcome everyone. And I am really feeling very good about the CPR class, because this is one science which has been associated with our fraternity, our specialty for a long time. I think you ask any specialty in India, you ask any medico in India rather, if you want to get a training, which is the specialty you will go to. So invariably, wherever, whether it's a trauma sciences, whether it's a critical care sciences, wherever the CPR is performed, one has to go to the anesthesiology. So this science is inseparable part of our specialty, and we are proud of it. And we are further proud of it because we have our own IRC council also, Indian Resuscitation Council, and that has been under the chairmanship of Dr. Chakra Rao sir. We have been now a member of ILCOR. So we are basically internationally recognized in the CPR sciences. So we have a very eminent faculty today, which will be introduced by Dr. Dipanita. And I will not take much time in elaborating the things, because this is a class to learn. And everyone who is joining the class today, they tell other people, colleagues also, that if you have not attended this class, you can always watch it on the ISA NHQ YouTube. So without wasting time, I hand over the mic back to Dr. Nishant and Dr. Dipanita.
Yes, thank you, sir. And today we have two eminent faculty, as I mentioned, and the faculty will be introduced by our young, dynamic, new coordinator, Dr. Dipanita Sutradhar. Dr. Dipanita, please.
Good evening, all my respected
Dr.
students.
Dipanita, she's a young person, young faculty from Silchar Medical College. It's my alumni only. So just wanted to showcase her also, this CV, small CV only. Thank you, Dr. Dipanita. Please go ahead. Sorry.
Thank you so much, sir. Thank you for the kind introduction. Our speakers today is Aunt Dr. Sucheta Tikre Madam. She is currently the Director Professor and Head of the Department in the Department of Anesthesiology in Mahatma Gandhi Institute of Medical Sciences. She has 22 publications, and she is a MUHS PG teacher, and she has guided more than 25 students research papers in the Nagpur University and MHUS University. She is an examiner in home and other university paper, setter evaluator. For her excellent work and her dedication, she has been she has won many awards, prominent of which are itself in the year 2017. She has won, I think, 5 awards: National Mahila Ratan Gold Medal Award, Vijay Ratan Gold Medal Award, Medical Excellence Award, Star of Asia Award, and Special Achievement Award. In the year 2019, she had won the Hind Ratan Award and Gem of Asia Educational Excellency Award. She has also won the International Gold Achiever Award by Global Achiever Foundation on the occasion of International Achiever Seminar on Globalization of Economic and Social Development at Moscow, Russia in 2019. In 2020, she has been awarded the fellowship in ACE Mechanical Ventilator Fellowship. She is a National Master Trainer in NELS, Primary Emergency Care and Life-Saving Anesthesia Skills. She is a AHS certified instructor in BLS and ACLS and an ISA certified instructor in BCLS and CCLS. Our next speaker is Dr. Dheeraj Bhandari. Dr. Dheeraj Bhandari, sir, is a very well-known figure, and he is a professor in anesthesiology and consultant intensivist in Mahatma Gandhi Institute of Medical Sciences. And he has won his gold medal in MD anesthesia in 2010 and was awarded a Dr. Deshpande Gold Medal in MUHS University. He was also the national best outgoing exam candidate in IDCCM exams of ISCCM 2014, and for which he was awarded Dr. Vijay Lakshmi Kamath Award. In ISCCM Bangalore 2015, he won the Young Talent Hunt Award, and at Isakon Jaipur, he won the ISH Narayani Award. He is also a certified AHA instructor in BLS and ACLS and an ISA certified instructor in BCLS, CCLS courses. He is also the candidate provider for ATLS-P. He has many publications, about 13 in 5 original articles, and he's also a MUHS PG teacher and also the member of the editorial board in the critical care section of JOACP and IGC. Thank you so much, sir.
Right. So thank you for the introduction, Dr. Dipanita. May we request Madam and Dr. Dheeraj to please introduce the students for today and how they plan to go ahead. You're muted, sir. Ma'am. Yeah.
Very good evening to all ISA office bearers, respected senior, dear friends and students. I take this opportunity to thank the ISA national team for giving MJMS this opportunity to take part in the national PG online classes on cardiopulmonary resuscitation. Anesthesiologists are called the master of resuscitation. You all will agree with me that anesthesiologists, by virtue of their knowledge, skill, attitude, are called upon by their colleagues in the hospital to resuscitate a sick patient or to do the CPR for a patient with cardiac arrest. We all do this with zeal and pride. Thus, it is not only imperative that such a skill is tested in examination. With changing pattern of examination in MD, DNB examination, and now even in UG examination, resuscitation skill will be tested time and again. We at MJMS established the skill lab under anesthesia from 2016. We had completed so far 4 AHA and 7 ISA accredited BCLS and CCLS training and close to 40 unaccredited CPR training program. Being an important topic clinically as well as for exam point of view, it is only but natural to revive ourselves again about the CPR. Let's go through the next 90 minutes of learning and interaction about CPR. I invite our Professor Dr. Dheeraj Bhandari to talk on the same topic, and our PG student Dr. Keshav and Suhas will help him in demonstration of the CPR. Thank you all. Shall I start?
Yes, Dr. Dheeraj, please start.
So the screen is visible, I suppose, and I am audible as well.
Yes, perfect. Good.
Okay. So first of all, thank you, ISA National, respected Bajwa sir, Madhuri madam, Dr. Nishan sir, all the ISA office bearers, and for giving us this chance to talk about cardiopulmonary resuscitation, and especially to focus on from how to face the Viva table on resuscitation. And we are very humbled for the same opportunity. So the learning objectives of this task will be basically to talk about algorithms and chain of survival. Then we'll talk about peri-arrhythmias, including the Brady and tachyarrhythmias and its management. Then we'll talk about some special population scenarios like pediatric pregnancy, and then we'll see what new updates are there currently. Now, when we talk especially from a exam point of view, we all know that there are certain things which are absolutely must know, and then there are certain things which are desirable. This is probably going to differentiate for an examiner a candidate who has read thoroughly versus a candidate probably who has just managed to do it in some sort of complete his Viva in the way. So CPR is one such skill. In the table Viva, almost we all agree that 5 minutes will be reserved for a CPR Viva. A demonstration of skill won't take probably more than 1 or 2 minutes. So if you are thorough with your basic life support skills, the examiner will readily focus on to the new challenging questions, the ACLS part of it, and probably some brain teasers, which will be then helpful for you to score further. But if you are not thorough with the basic life support skills, probably you will get still stuck into the same thing again and again. So it is very important that the must know part, that is the basic life support, is something we do. There is nothing to conflict of interest from our side at department here. To further expand the outline of this talk, we'll talk about history of resuscitation, we'll talk about the ILCOR membership, we'll talk about epidemiology, we'll talk about pathophysiology of cardiac arrest, we'll talk about how the guidelines have evolved over a period of time, we'll talk about the various guidelines and the chain of survival. Then we'll talk maybe touch a bit upon drugs and equipment in CPR, including defibrillation, airway adjuncts monitoring, automated chest compression device, ECMO POCUS. We'll talk about resuscitation, post-ROSC care and neuroprognostication. And of course, we'll see some of the special scenarios. Now, as you all will agree, there are some of these which are absolutely must know, and some of this will be desirable to know. But as the Viva keeps on progressing, you might find all of this helpful. So coming to the history of resuscitation, history is very important, isn't it? It all tells us from where we started and where are we likely to progress in the same is true with the history of resuscitation. Here you can see bellow method being used by Swiss physician and Dr. Peter Safar in 1956 doing mouth-to-mouth resuscitation. These are considered some of the most pioneer works in early resuscitation. We all know this as a Safar's airway. Many a time, especially the senior examiners would like to keep this as a spotter in your exam or Viva in their examination, and we all need to know this thing. To just look into the history, in 1774, London physicians, they found the Society for Recovery of Persons who were apparently drowned. Then there was the Hall method and the Sylvester method, where they used to do some sort of resuscitation. And today we are still using the resuscitation method of recovery position. In 1924, this is the landmark where the 6 cardiologists in Chicago met and they formed the AHA, as we talk about. In 1950, the Circulation Journal published. And you can see a Hopkins closed chest defibrillator, which was built by the physicist and the team of doctors at John Hopkins Institute. And this is what paved the way for resuscitation and early defibrillation. In 1960, Resusci-Annie is born. This is something which we have been again using day and night out in our old simulation-based skill lab. Not only Resusci-Annie, but various companies are now manufacturing. The history is pretty interesting. This was a doll-making company, and they came together with medical scientists to establish something called for helping the skill lab to demonstrate about the resuscitation. In 1963, the AHA endorsed the CPR. In 1966, there was the first ad hoc conference on resuscitation. It's almost 50 years now. In 1972, Dr. Leonard Cobb did world's first mass citizen training in CPR. So have a look at it, how we have progressed over a period of time. In 1975, the AHA published the first ACLS textbook. In 1981, there was telephone CPR as a pilot project in Washington County. In 1988, first pediatric courses were done. In 1990s, public access defibrillation program was started in the USA. In 1992, the International License Committee on Resuscitation, that is the ILCOR as we call it, the umbrella body for resuscitation, was found. In 1999, there was the first international conference on guidelines for CPR and ECC. And after that, over a period of time, many guidelines have come, which we'll see over a period of time. We were proud that in 2017, in Indian Journal of Anesthesia, we produced and we published the guidelines for compression only life support, BCLS and CCLS. And this is something now slowly we are over a period of time establishing. In January 2023, the Indian Resuscitation Council Federation became the approved member of ILCOR, along with other prestigious societies like European Resuscitation Council, the AHA, the Australian and New Zealand Council, and the other councils. Now coming to the epidemiology part of it, it's very important that whenever we are doing any intervention, we understand its epidemiology, not only for allocating right amount of resources, but at the same time, we should be aware that what are the outcomes which we can expect. Now here we can see two important terms which are commonly being used. The examiners might also ask you this thing. One is out of hospital cardiac arrest, and then second is in hospital cardiac arrest. As expected, out of hospital cardiac arrest will have worse outcome than in hospital cardiac arrest, and the numbers are pretty much bit depressing. But then that is how it is. Over a period of time, these numbers have improved, and slowly we'll have the data from our own Indian scenarios also. The survival rate varies with geographical area, presumably with different condition, and also because of the different resources available. The Western and the developed countries probably having an upper hand into this, but slowly we will be catching with this thing. When we talk about outcome from a CPR patient, this is something all of the postgraduate students, even the newly joined PG students, they must have also joined a call of CPR when the code blue has been activated in your respective colleges. We talk about in the terms of whether my patient could get a ROSC or whether my patient didn't have a ROSC. But that's only one of the whole component. The overall outcome when we talk about CPR should be survival to actually discharge. The patient has now just only gone to ICU. He might not make it out of ICU. Secondly, even if he makes out of ICU, whether there was an intact neurological survival to discharge, this is very important. And thus, it is very important, at least in the cardiopulmonary resuscitation, for all of us to understand that time is very much of essence. And with every passing minute, the chances of successful outcome decreases significantly. Now, I'm not going to go into details of pathophysiology, but this is something which you might get a question into. There are three phases of cardiac arrest. One is the electrical phase, the immediate phase, followed by hemodynamic phase, and the last phase is the metabolic phase. The electrical phase is the most important or the earliest phase, from early 4 to 5 minutes of cardiac arrest, and most of the time the rhythms present will be shockable rhythms, most likely ventricular fibrillation, and immediate defibrillation in this time significantly save lives. And that is why the emphasis of defibrillation incorporated into basic cardiac life support or the BLS or the BCLS guidelines. And that is why the public access defibrillation, the public AEDs which you see, becomes very important. As time passes, now look at the time, it's very short time. After 4 minutes, that is around 4 to 10 minutes, is the hemodynamic phases, and the initial electrical phases rhythm, that is the coarse VF, will change into fine VF, and if not corrected, will ultimately progress into a non-shockable rhythm like asystole or pulseless electrical activity. This is the phase when myocardial energy depletion becomes more pronounced, and this is the reason where the advanced airway or you are more focused on adequate chest compression so that your myocardial energy stores are replenished, and this will lead to a successful defibrillation. And then the last phase is metabolic phase, which is generally more than 10 minutes which have been passed. There you'll see most of the time non-shockable rhythms. Generally, it is said that there will be a poor survival if it is after more than 10 minutes. But the basic idea again is that we need to continue to look into the reversible causes of treatment and continue to treat them, and that will increase the chances of survival even during this phase. So it's very important that PGs remember these three phases of cardiopulmonary resuscitation. As you can again see with this diagram, over a period of time from early electrical phase to just a minute. From an early electrical phase towards the last metabolic phase, the survival decreases significantly. Now, how does the CPR work? We all know that we give chest compressions and probably the heart is getting squeezed in between the sternum and the spine behind. So that is one theory, that is the cardiac pump model. The second model is known as the thoracic pump model. So basically in the thoracic pump model, it is generally said that probably the overall circumferential compression, it causes negative intrathoracic pressure, which will increase the venous return. And when an active compression is done, probably it will lead to the next artificial systole. So probably in real life, both these theories, that is the cardiac pump theory as well as the thoracic pump theory works, and it is important for us, for the PGs to know about this thing. So we need to know definitely about the algorithms, how to perform a given set of skill, and that if you have done very fastly, then the Viva will start going towards all these questions where it will be important for you to score marks if you know these things. Now let's see how the guidelines have evolved over a period of time. So we know in the initial phases we talked about ABC, but now the current guidelines talk about CAB approach, that is circulation first followed by airway and breathing. This approach was changed in 2010 because the chest compressions were recognized very early. So this is a nice diagram if you can see over here. So this is basically again the ILCOR guidelines, the AHA guidelines. If you see it in 2000, 2005, 2010, 2015, 2020, anyhow we are going to talk. So what we see over a period of time, you see the CPR sequence. In 2010, ABC was changed to CAB. So this becomes very important for us. Then look at the compression rate. At start, it was at approximately 100 per minute. Now look at the change in the wording. They said at least 100 per minute. And this was the time when they said that push hard and push fast to be emphasized. And in guideline 2015, they say 100 to 120 is probably ideal. And what ISA or IRCF guidelines now say is pretty much the same. That is 120 beats per minute. Now, if you look at the compression ventilation ratio, in 2000, it was 15:2 uniform. If before that, if we talk about in 1992 HA guidelines, it was 5:1. Then it got changed to 30:2, and now it has become uniform. So when guidelines are being created for such a common scenario where people from different fraternities are going to use these guidelines, even simple MBBS doctors are going to utilize this guideline, it becomes very imperative that the guidelines are kept very simple, and algorithmic approach is something which is easy to remember. Now again, very important for all of us to note, in 2010, the look, listen and feel component has been removed along with changing from ABC to CAB. Now this ABC versus CAB scenario is something which is always confusing, even when the prelim examinations are taken for the student. So what we need to understand is there can be any emergency for this patient. The scene safety has to be assessed for this patient, and we all need to assess the patient for responsiveness. We need to call for the help at the earliest opportunity, and this should be followed by pulse and respiration. Now, if the pulse and respiration is present, now this patient will undergo the ABC approach. That is our approach to any emergency patient, where we talk about airway management, we talk about breathing maintenance, and we talk about circulation. Currently, this is not our topic of concern, so I'm not going to focus on this thing. But the second aspect is, if the pulse and respiration are absent, that means this has been a cardiac arrest. So then the approach changes from ABC to CAB. So circulation becomes very important, and the idea or the target is to maintain the blood supply to vital organs. And how do we do it? We do it by giving a chest compression at the rate of 120 per minute, or high quality chest compression, what we call. And then this is supported with airway and breathing functions over a period of time. So this difference between ABC and CAB should be very clear to all of us in this thing. Now, this is again, whenever any emergency is being done in any part of the hospital, be it in awake sick patient or be it in a cardiac arrest patient, this is a teamwork. The team dynamics comes into play significantly, and we'll see over a period of time what these team dynamics are. Now let's come to the next part of our talk, that is algorithms and chain of survival. Now these algorithms and chain of survival are very important. They have evolved over a period of time. Now what is chain of survival basically? When we talk about chain of survival, basically they are very tightly interlinked set of action which, when done in a timely fashion, in an appropriate fashion, will lead to ultimately increase in the outcomes of the patient. But they are very much linked to each other, so you cannot skip one step and probably go straight away to a next step. So this chain of survival becomes very important. So we talked about three important guidelines, that is compression only life support guideline. Then we talked about basic cardiac life support guidelines or BLS guidelines. And then we talk about the CCLS or the comprehensive cardiac life support or the ACLS guideline. Basically, COLS or chest only compression as we call it, this is for lay person with no access to any gadgets. It include at least chest compression, which has been shown to improve outcome as compared to a patient who has been done nothing. For example, suppose if a lay person is there outside in a market, he sees a patient who has been collapsed. The original guidelines is to say ABC. Now the ABC was airway opening and breathing to be given. And if there are no gadgets, the mouth-to-mouth breathing was something which was supposed to be given. With the concerns about safety, hygiene, infectious causes, people were reluctant to give this thing. And what they thought was, because I have to start with airway and breathing, they never used to proceed to C part of it. Secondly, over a period of time, we realized that chest compressions are more important. So at least why not give chest compression? And it has been shown that giving at least chest compression will significantly improve the outcome as compared to doing nothing, just calling the ambulance and waiting, because the initial crucial time will go. So in this COLS algorithm will have early recognition and activation followed by early chest compression, and then this will be followed by a early transfer to the patient. Now coming to the basic cardiac life support guidelines. So basic cardiac life support, there are 4 chain of survival. So early recognition and activation, high quality CPR, defibrillation additionally becomes very important, and the word is early defibrillation, and then of course early transfer to a hospital or an intensive care unit where there will be a management for ACLS or advanced ICU care management. And that brings us to the CCLS or the ACLS guideline. So here again, early recognition is also very important, but at the same time, if possible, we should be able to prevent this condition. Then early recognition and activation of code blue. CPR becomes very important, defibrillation becomes very important, but then additionally things like drugs, advanced airway gadgets becomes very important, and this is followed by post-resuscitation care. So if I have to sum up the difference between COLS, BCLS and CCLS, again in a very crude way, I'm not saying it's an absolute way, COLS is basically recognition and then chest compression and then transfer. In BCLS, the same components will be there, but along with this thing, you will have a component of giving breathing as well as early defibrillation becomes very important. So BCLS is basically COLS plus airway plus early defibrillation. And when we talk about CCLS, CCLS also involves basically to prevent this condition if the patient is in hospital by using scoring system. But at the same time, it is BCLS, that is your chest compression, airway, then your early defibrillation with advanced airway, advanced gadgets, advanced monitoring. And if the patient gets a return of spontaneous circulation, that is ROSC, then the post ROSC care becomes very, very important. We'll come to that part as to why post ROSC care is equally important. It is very important to know statistics that 4 out of 10 patients who had a ROSC will again go into cardiac arrest, especially if the reversible causes are not done, especially if there is not a high quality of post ROSC care. Now this is the AHS chain of survival for in-hospital arrest and out of hospital cardiac arrest. You see there's not much difference. Basically, it's basically recognition, activation of emergency response, that is code blue, high quality CPR, defibrillation, post cardiac arrest care and recovery. In out of hospital cardiac arrest care, because the patient is already inside the hospital, the only important thing is if he's in a ward or somewhere, if the patient is in out of hospital cardiac arrest, this patient will have to be shifted from scenes to the hospital, and therefore ambulance transfer becomes very, very important as compared to in hospital cardiac arrest care patients. Now let's see one of these algorithms one by one. Now let's come to the BCLS algorithm. So we all know the BCLS algorithm, and probably you can do a check in the back of your mind. And the most important steps are, I'll not go through all the slides immediately, but the first and foremost important thing is we need to ensure a safety or a scene safety. Next, we need to check the response, and this response is basically checked on the shoulder of the patient in an adult patient, and then we ask the patient in their native language whether their patient is doing okay or not. Now, this might seem to be a very small instruction. I mean, like, people might seem that there is nothing great into it. But what we are trying to see here is that out of our maximum senses, that is the stimuli, we are trying to utilize most of them to see whether the patient has response or not. We are giving a tactile stimulation to the patient. We are doing it on bilateral side, so that even if there is a ipsilateral hemiparesis, hemiplegia, the patient will still be able to respond. We are looking at the patient for the response. We are trying to listen if the patient is giving any response, that is using our auditory stimuli. And at the same time, all these senses when combined together will give us an idea whether there is a verbal response or if there is any purposeful movement. This becomes very important. The moment you see that the patient is responsive, probably this patient needs to be shifted to recovery position, not in trauma cases, and then be shifted to nearest medical facility. The scenarios can be anything, isn't it? The patient had hypoglycemia, the patient had coma for whatever reason, patient had hemiparesis, had a altered response. These patients will have breathing, these patients will have pulse, but they will have a problem with their sensorium, and still they need to be shifted to the medical facility. If the patient is non-responsive, we need to call for help. This is the most important thing. BCLS is a teamwork, CCLS is a teamwork. So alone person, single person cannot do. But at the same time, what is important is, if you are in a hospital, you need to activate the code blue. And if you are out of hospital, probably you can get someone to come and help you. They can call 108, the ambulance number, while you continue to do. If you are lucky in a scenario where, like in railway stations, malls, or airports, where you have AED or defibrillator, you can get those things. If you are in a ward, you will have crash carts, you will have your defibrillators, either manual or AED, and then you will be able to do further additional BCLS response to this patient. Now, when you call for help, this becomes very important as to clearly instruct what has to be done. So, for example, I cannot say there is a patient and come for help. Where is the patient? How many number of patients are there, isn't it? So this clear instruction becomes very important. Same stands true for code blue in the hospitals also. For example, imagine there's a patient in ortho ward. A patient has collapsed in ortho ward. The intern or the junior resident is calling code blue. Probably the anesthesia team has picked up the phone and he is in a panic mode, and all he is saying is, there's a code blue, please come fast, and he keeps the phone down. Now the problem is, it's very difficult to understand from where that phone has come. So there's something, the team dynamics come into play, that is a closed loop communication, clear instructions. Wait for the person who has given the instruction and the person who has received the instructions to be comprehensive, that both of them have understood the instructions and they are coming to the help at the scene of the accident. So the first three steps, that is safety, response, and if non-responsive, then help. In the help, at least three things are important: get help or activate code blue. Then second is get AED or manual defibrillator, and get crash cart, which will contain your emergency drug and equipment. These three things are very important. After that, you will check breathing and you will palpate the carotid pulse within 5 to 10 seconds. Now again, very small step, but very crucial step. Now remember, this is a dichomatous response. You are not checking or you're not counting the pulse rate at this stage, or you're not counting the respiratory rate at this stage. What you are doing is, you are simply checking whether my patient has respiration. The answer is yes or no, and simultaneously whether I am able to feel carotid pulse, yes or no. Again, the question might come to you, why carotid pulse? Because we all know it's a central pulse. Even in a state of shock and something, you'll still be able to get a central carotid pulse, even if it is feeble, not like parotid pulse. Again, there's a way to do carotid pulsation. That is something which we'll demonstrate. But just for the sake of time, you start from the center, you keep your three fingers from the center, and then you go to your ipsilateral side of the neck, and the first groove or the first depression where you find, you will be able to feel carotid pulse most of the time very easily. So this is something which will teach our students over a period of time, and students also, they will be learning the same skills in the skill lab or the simulation lab. Now this has to be done within 10 seconds. Now again, you cannot keep a watch next to you, isn't it? If you are keeping a watch next to you, then you are not looking at patient's respiration, isn't it? So you need to count out. Again, how do you count? If you say 1, 2, 3, 4, 5, there might be again a variation. Somebody might count it very fast, somebody might count it very slow. So one of the ways which has been devised is to count probably in the range of thousands, so which will correspond roughly to 1 second. So what you say is 1001 or 1001, whatever is comfortable. So if I have to check the pulse and respiration, I'll say 1001, 1002, 1003, 1004, 1005, 1006, 1007, and that is something which will actually correspond to the that duration of 1 second. Now here can be three scenarios. One is you are having a normal breathing with definite carotid pulse. It's basically what we saw the scenario before. And now the second thing is you are having a pulse, but the breathing is problematic. Now this is something like a respiratory arrest, and you continue to need to reassess this patient while providing artificial positive pressure ventilation. That is one breath every 5 to 6 seconds. That is 8 to 10 breaths have to be given for this patient, or 10 to 12 breaths per minute has to be given to this patient. Now, what these scenarios, can you guess some of the scenarios? A simple thing, patient is in ward in the night, there is a post-operative cases, and the patient is complaining of significant amount of pain. The staff is alone. I'm not blaming anyone, but then decide, okay, let me give some opioid or some medication, and a significant amount of opioid is given, and the patient goes into respiratory depression. This becomes very common. A patient had a posterior stroke, again a common scenario. So we need to differentiate between normal scenario, a respiratory arrest scenario, and ultimately a scenario where there is no carotid pulse or no respiration, and the patient has complete cardiac arrest. So now what happens if the patient has a cardiac arrest? So now we need to give chest compressions to this patient. All of us are seeing this even way before you entered into your post graduation. You must have done this into your medical schools, the undergraduate days. Even before your undergraduate days, you must have seen somewhere this being performed. But there's a difference between a normal chest compression or normal CPR, and then there's a difference between a high quality CPR. If you are trained to give high quality CPR, the outcome will be definitely much better. So as much as CPR is of a knowledge component, it is equally a component which needs a skill practice in a skill lab along with development of attitude. So now what are the components of good or a high quality or excellent chest compressions or CPR? The first and foremost is the hand position, how you keep your hand position, then how much you compress, isn't it? So 2 finger above the xiphisternum, you lock your hand into the sternum, and you keep your elbow straight, and you have your body weight or your aligned with this thing, so that you get a good chest compression, and at the same time you are able to do a recoil. How much chest compression you have been able should be able to do? At least 5 centimeter, but not more than 6 centimeter. This is very important. Then the compression should be at a speed of 120 minutes per minute. There should be a chest complete recoil. Now the reason for this chest recoil is, if you don't allow the chest recoil, there will be no venous return. If there is no venous return, it is basically of no use, because you are almost pumping an empty heart, so which is not going to be a good effective CPR. So chest recoil becomes very important. Do not stop chest compressions unnecessarily. This is something I think which we see most of the times. When you go to attend a CPR call, you will see suddenly some senior person is coming. He'll say, I will be intubating this patient, stops chest compressions. Somebody will be coming, okay, let me take a central line and just wait for 2 minutes. I'll get a central line, we'll be able to give drugs directly. Somebody will come and they will say, no, let me do a USG or something. So what we need to understand is, for whatever reason, chest compression cannot stop during the CPR. They are the single most important intervention, along with early defibrillation wherever applicable, which has been shown to improve the outcomes, not the other interventions like intubation or IV access or anything as much, isn't it? So this becomes very important, and that is the reason chest compression is included in your calls, it is included in your BCLS, and definitely it is a part of CCLS guidelines. Now we should count this thing very loudly as to how much we are rhythming, because it's a coordination. When you are counting nicely, then your breathing person will understand, okay, that it is near the ending of 30 compression, and I'll have to count coordinate my breathing very clearly. And if there are more than one person, one should interchange every 5 seconds so that fatigue doesn't come in. This is again a common scenario. People will be, oh, I cannot get fatigue. No, it is proven scientifically that over a period of 1 minute to 2 minutes, there will be significant arm fatigue and your chest compression quality will go down. So all of us definitely, this is must know. This is must know scenario in your Viva, how to give a good quality, high quality CPR, isn't it? Now the next important skill is breathing, bag and mask ventilation. You can give single hand technique and you can do both hand technique. I will not be dwelling onto this thing because as an anesthesiologist, this is something which we all are masters and there are separate classes for each of these things. Now when you have two rescuers, the advantage is less interruption, better respiration and switching the role at 5 cycles, longer resuscitation with exhaustion. Now the most important component, whenever the defibrillator is present, AED is present, that is automated external defibrillator is present, AED will take preference over your airway. So the first thing is the one person will continue to do chest compression. If the second person has brought an ambu bag as well as AED, the AED will take precedence over ambu bag in the starting phase. And after once the CPR, that is the defibrillation as chest compressions have been established, then simultaneously in coordination will we look towards the the CAB component of this. So this is very important for all of us to understand. COLS, I'm re-emphasizing again, chest compression, BCLS, chest compression plus early defibrillation plus airway. In that sequence only, if you remember, that will emphasize the role. And CCLS is basically BCLS plus advanced airway, advanced gadgets, advanced drugs, and reversing the causes of cardiac arrest. Now coming to the CCLS algorithm. So how do we look into the CCLS algorithm? Again, the scene safety, response, responsiveness, non-responsiveness, and then we are working the BCLS scenario similarly. And then whenever defibrillator is available, the preference is given to the defibrillator, and then we will talk about the advanced part. Now, defibrillator, there are two ways. One is the AED, that is the automated external defibrillator, and second is your manual defibrillator. In medical scenarios, as you will all agree that the medical names most of the times will be given very thoughtfully, isn't it? If there is an automated external defibrillator, that means there is a certain meaning to it. Automated means this does two things automatically. First is it analyzes the rhythm for you automatically and it provides you whether this is a shockable rhythm or not shockable rhythm. These two things are something which are very important for us. The shock part in manual defibrillation as well as AED, both have to be done by the operator. So this is one important thing which all of us needs to remember. Now in the new built monitors, you have monitor and defibrillator, and in the same defibrillator you will have capacity for AED also. The problem with AED is the pads, the disposable pads which are required for them are costly, and at times you might not have enough stock of this thing. So at least for us as anesthesiologists, we need to master the rhythms of ECG, especially the tachyarrhythmias, bradyarrhythmias, and the cardiac arrest rhythms, so that we are able to clearly differentiate when my patient is into shockable rhythm and when my patient is not into a non-shockable rhythm. We'll come to that part in a short while. Now, this is the advanced part of it or the comprehensive part of it. So once the BCLS has set in, that is you have started your CPR, you have started your defibrillation has been given, airway person in the chest compression person are doing it in nice coordination, your whole team comes into picture, and once the team comes into picture, then they can be doing a different type of job. Like somebody can be doing a venous access, somebody can be looking at the monitor, somebody will be able to do a recording, and one of them will be team leader. So now let's talk about the team dynamics for the CCLS. So in a skill-based scenario, in a team-based scenario, for COLS, we say even one person, if it is there, he'll be able to do COLS. For BCLS, one person if he's there, he'll be able to do it, but ideally you should have two persons to do it in an effective way. And for an ACLS or CCLS, ideally there should be 6 persons who are there. So we'll come to those 6 persons, what their roles are, but one of them has to be team leader, one of them has to be an airway provider, one of them has to be a chest compressor, one of them has to look after drugs, one of them will be recording this, all these things which are happening, and another person will be helping with monitoring or the miscellaneous job, isn't it? Now, what are the once the patient has been revived over a period of time, then post-resuscitation care has to be taken into account. So we'll come to these individual components and we'll break them. Now, when we talk about shockable rhythm and non-shockable rhythm, now how do we decide whether the rhythm is shockable or non-shockable? So the cardiac arrest has basically 4 different rhythms for cardiac arrest. One is the asystole, second is the pulseless electrical activity, third is the ventricular fibrillation, and fourth is the uh, your ventricular tachycardia without pulse. Now, out of this thing, the shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia, and the non-shockable rhythm are asystole or pulseless electrical activity. Again, pulseless electrical activity, people will get confused, but it's a very simple acronym. What we understand about the heart is heart has 2 important ways in which it functions. First is the conduction system, that is the electrical conduction system, which will create different rhythm, and this will be followed by a mechanical contraction, which will actually create a pulse. So what happens in a pulseless electrical activity is you will have an electrical wave, or there is a conduction, you will see an organized rhythm on the monitor, but if you check your pulse, the pulse is not there, and this is something which will represent a pulseless electrical activity. Now, why I have highlighted this part of the diagram is, if you see into VF and pulseless ventricular tachycardia, the shock takes precedence over even the drugs or anything else, isn't it? So I have just cut paste the half of this slide, and if you look at the asystole and pulseless electrical activity, because this is not a shockable rhythm, epinephrine becomes important while continuing the CPR. So this is very important for all of us to remember this important difference. Now, we all know that in CCLS, the additional important thing other than the advanced gadgets, the advanced drugs are to look for the reversible causes which can be corrected, and probably the patient can come into the cardiac arrest. Now, there are various mnemonics. The ISA IRCF guidelines talk about the hit the target, and the reversible causes from the ILCOR or AHA, they talk about the 5H and 5Ts. Now, the easy way to remember, this is something which will be asked to us very commonly. Now, the easy way to remember your 5H, 5Ts or hit the target is, you can start from, say, if you're talking about the H, we can talk about the 5 important components. That is the volume, oxygen, the hydrogen ion, that is acidosis, the potassium, and the temperature. So if anything excess or decrease is there, these are the reversible causes. Now coming to the T's, that is 5 T's, we'll have first is toxins. Let's talk about toxins. And then 2 will be, one is the thrombosis of either pulmonary or thrombosis of coronary, and that's another is tamponade, basically obstruction. In cardiac we call it as a cardiac tamponade, in the respiratory system we call it as a tension pneumothorax, just to remember things easily. So 5H will be your 5 important component: volume, oxygen, acid ions, potassium, and temperature. And your 5 T's will be toxin, 2 thrombosis, and 2 obstructions, that is cardiac tamponade and tension pneumothorax. So one needs to continuously keep looking at all of these conditions. So if I have to revise the CCLS guidelines, so how will I approach this particular patient? So the initial things will, you will start with the BCLS approach. The moment your team comes into, you will assign everybody the role. Preferably, this should be pre-assigned itself. The senior most person who is well versed with all these algorithms, he should take the position of team leader. And then during your CPR, there should be significant amount of coordination happening between all the teams in a very nice fashion, so that the whole thing, the whole flow of the CPR, it looks very musical, it looks very clean, that nothing is being missed out, isn't it? So this is something which we'll see in a short while. Now, before that, we'll come to approach to arrhythmias. Now, as we say commonly when we talk about a patient in ICU or anywhere, we have a common tendency to say, sir, patient जो है वो suddenly cardiac arrest में चला गया, or my patient suddenly went into cardiac arrest. Generally, your patient most of the times will have some sort of indication. Your patient will give you some indication in your ABC, which if picked early, probably you will be able to prevent your cardiac arrest. Not in all scenarios, but definitely it will be helpful. So there is nothing like sudden cardiac, I mean like patient suddenly went into cardiac arrest. He will give you some sort of indication. So most of the time your patient before going into cardiac arrest will have some sort of arrhythmia. Either it will be a bloody arrhythmia or tachyarrhythmia, and if it's a stable rhythm or unstable rhythm is something for us to find out. So how do we approach this arrhythmia? First is to look at the rate, that is Brady or Taki, then to look at whether it's a stable or unstable rhythm. How do we decide if it's a stable or unstable rhythm? Is basically the heart is not able to perfuse, and because of this thing there will be a significant hypoperfusion, and this will give you some sort of signs and symptoms. Now what are the signs and symptoms which you will be able to see? Hypotension can be there, you can have altered mental state, you can have signs and symptoms of shock, you can have ischemic chest pain because of end organ hypoperfusion, you can have acute pulmonary edema happening at the same time. To remember this thing, again the mnemonic is basically HASIA or charts, whatever you want to remember. So this is something we'll try to look into a focus history whenever we are approaching a sick patient. So if a sick patient comes to me, we have seen the initial slide, we talk about the patient's scene safety, we talk about the patient's responsiveness, we look at the monitors are attached, we take care of the airway, breathing and circulation by looking at the monitor, we do a focus history. In those focus history we look at this important danger sign, that is the HASIA signs, and based on this thing we decide whether my patient has Brady or tachyarrhythmia and whether it's a stable or unstable rhythm and how fast I need to intervene into this thing. Now let's come to bradyarrhythmias. Now currently, in this scope, it is beyond the scope of this chapter to talk in detail about bradyarrhythmias and their identification. But to just rapidly go through it, we need to identify the rate, we need to identify the rhythm. So this is a normal looking ECG, but if you look at the PR interval, the PR interval is prolonged. So if the PR interval only is prolonged and your rhythm is very regular, this is a first degree heart block, isn't it? PR interval more than 0.2 seconds is first degree heart block. Now look at this this second ECG. Keep a watch with my pointer. The PR interval is there, followed by ST. Then the PR interval has increased here, but there is still a QRS. Then the PR interval has further increased. This is followed by QRS complex. Now again here if you look, the PR has significantly increased. Now here if you look after this P, there has been no QRS complexes, and again it will start normally. So basically there has been a prolongation of PR interval over a period of time, and then there has been a fall in a there has been a missed bit. So this is second degree type A or MOBIS 1. In MOBIS 2, what you see is the PR interval is more or less fixed. It can be wide or it can be close, but then there will be a bit where you will have no P wave. I mean, you will have a P wave, but there will be no QRS complexes. So what will happen is this is an advanced degree or MOBIS type 2 block. So one important thing to remember is first degree heart block generally will be a regular rhythm, but because in MOBITs type 1 and type 2 we have missed bits, you will find these rhythms as irregular one. Now this is type 3 or AV heart block. How do we say this is type 3 or AV heart block? Because you can see there is no correlation between the PQRS complexes. Now if you see here, there is a QRS complex, QRS complex, QRS complex, QRS complex, pretty much coming at the same rate, but this is a significantly slow rate and a wider QRS complex, suggesting probably its ventricular origin. And if you look at the P wave, they are coming at their own timing, but that timing is also quite frequent. So basically, P wave is coming at their own time, QRS is coming at their own time, and there is no coordination. And at times you will see a P wave which is intermingled between the QRS complex. For here, look at this QRS morphology and look at this QRS morphology. There is a notch here, probably suggesting that the P wave has merged in here. Now look at this P wave. This is very close to this QRS complex. So you need to identify the third degree heart block. Now the treatment for all of this thing is, again, the initial approach becomes the ABCD approach. We talk about the hypotension, acute, the HASIA signs. If the HASIA signs are there, that means my patient is unstable, and then I need to start the treatment. The first line of treatment is atropine. The first dose is 1 milligram, which is followed by 3 to 5 minutes higher doses. So we can repeat up to maximum 3 milligram. Then if atropine is not working, either I can use a dopamine or epinephrine infusion, and the dosages are pretty standard, 2 to 10 microgram per minute infusion. And of course, if this is not helping us while you have started treatment with atropine, you should call for an expert help. You can either call a cardiologist, you can call an intensivist or a cardiac anesthesiologist or a senior anesthesiologist who can help you, or an internal medicine guy who can help you. And in the meantime, meantime, transvenous pacing is an easy option. It looks difficult, it sounds difficult because the pacing word is there, but it is very easy provided you have the right amount of equipment. And the reversible causes, of course, needs to be learned into. So this is an approach to bradyarrhythmia of the bradyarrhythmia. Now let's talk about the tachyarrhythmia. Again, identify that the patient has tachycardia, identify whether my patient is stable, unstable. Now there are two important additional questions in tachyarrhythmia. One is the QRS complexes, whether they are normal or wide, and secondly, the tachycardia, whether it is regular or not irregular. So this is what I'm looking into: a narrow complex or wide complex QRS, regular or irregular. Based on the permutation and combination, I can have different scenarios. We are not looking into a clear-cut diagnosis. The ACLS also says that in emergency, we are not ultimately, yes, a diagnosis of what exact tachyarrhythmia was there has to be made. But during an emergency, a syndromic approach is something which is important, and we need not go to an exact diagnosis, whether it was a particular PSVT or re-entrant or a multifocal or this thing. We are looking into a syndromic approach, and this syndromic approach can be the permutation and combination of these two important questions. So if you have a narrow complex and a regular tachycardia, your options will be either sinus tachycardia, supraventricular tachycardia, PSVT, or atrial fibrillation. I am sorry, the ECGs which I have put over here have disappeared. The another thing is, the next combination can be you have a wide complex tachycardia, but then again the rhythm continues to be regular. The example will be monomorphic ventricular tachycardia. Now the third combination can be you have narrow, but this time from this particular end you have an irregular rhythm. So narrow and irregular rhythm. The most common will be atrial fibrillation. Another example can be multifocal atrial tachycardia. And the last is you have wide complex, but also you have an irregular one, and these are the most dangerous: ventricular tachycardia, ventricular fibrillation, or torsades pointes. Now this approach becomes very important for us. So especially when I am teaching to my postgraduate student in the early stages, I don't want them to come to a diagnosis if I'm showing them an ECG rhythm and they identify that this is atrial fibrillation. Probably not a good way to start with this thing. They might be guessing it, they might be doing it in the right way, but the way they can approach is, sir, this is a tachyarrhythmia or a tachycardia, this is a narrow complex QRS, this is an irregular, this is most likely to be an atrial fibrillation. This gives me the thought process. So in exam also, if you are coming to a diagnosis straight away, probably the examiner will say, okay, good, or probably he'll say you must have guessed it. But if at the same time, if you say, if he has shown you an arrhythmia and you say, sir, this is a narrow complex regular tachycardia, most probably paroxysmal supraventricular tachycardia, the answer will be self-explanatory, and it will show your thought process also, which will straight away take you to the next level of set of questions rather than getting stuck into the same thing. Another important thing into the usefulness of this is we can easily remember about the joules which are required to change for the cardio version. For a narrow and regular, you will need a less amount of joule. For a wide and regular, again a less amount as compared to a narrow and irregular. So the most important culprit amongst all of this is an irregular rhythm. After that, it is a wide one, isn't it? So the bad guy among all of this is wide and irregular, and we generally don't talk about cardioversion, we talk about defibrillation. So that will bring to a new question: what is cardioversion and what is defibrillation? So cardioversion basically is a very simple thing, isn't it? So it's a English nomic. A cardioversion means I have to do a cardioversion. I don't like the current version of the ECG rhythm and I have to change that version. So I am doing a cardioversion. Cardioversion can be a pharmacological cardioversion, it can be a non-pharmacological cardioversion, or it can be an electrical cardioversion. For example, a non-pharmacological cardioversion can be simple your vagal maneuver. A pharmacological cardioversion can be with use of drugs like amiodarone, adenosine, beta blockers, and an electrical cardioversion can be because of use of synchronized doses of, say, whatever amount of joules you are using to match it with the QRS complexes, and you can do a cardioversion. But defibrillation is something which is different from routine cardioversion. There is no synchronization which is happening, and you are straight away giving a shock to completely defibrillate a fibrillating heart. So this is the important difference between cardioversion and defibrillation. Now, if you look at the tachycardia algorithm, the initial approach pretty much remains the same. We look at the danger sign, that is ASIA sign, and then we talk about whether my patient needs a pharmacological or a non-pharmacological version. So look at this algorithm. If my patient has danger signs, that is Hasia signs, I cannot probably wait for significant amount of drug therapy or non-pharmacological therapy to happen, and straight away I might use a synchronized cardioversion. Again, your threshold should be very good. Just a BP of a patient coming to 96 by 60, a previous BP was 106 by 70. This is not significant enough, isn't it? So all these signs has to be taken together in the clinical context. But at the same time, you see a patient has a PSVT, there are not significant amount of danger signs, then your next question ask is whether my patient has a wide QRS complex, yes or no. If there is a yes, then probably you will consider some amount of antiarrhythmic medication. If the patient doesn't have wide QRS complex, then you can even start with simple vagal maneuver. Then you can talk with adenosine. Then you can talk, if that is not working, about beta blockers. And of course, whenever this is happening, you will have to take an expert consultation. We will have to know the dosages or of all these things, and at the most important, the indications are important, but the most important things are side effects and contraindication of the drug whenever you are preparing for your viva. So if we look at that dosing part of it, the adenosine first dose is 6 milligram. It is followed by a rapid push by a normal saline, and second dose is 12 milligram. Again, remember, in cardiac arrest, all the drugs are pushed fast with a bolus of normal saline being given, or a ringer lactate, whatever fluid you are using. But in real, in a patient who is not into cardiac arrest, there are only few drugs which you actually give sort of a bolus. One of them is a adenosine, because it's a very short acting drug. Secondly, adenosine, when you are giving, the patient might experience a chest tightness. If your patient had a bronchial asthma history or something, the patient might develop bronchospasm. So all this history needs to be taken. The other antiarrhythmics, the most commonly what we talk about is the amiodarone. We need to know the dose of amiodarone. If with the patient in amiodarone, the only thing I want to highlight here is the amiodarone dosages in cardiac arrest are different from amiodarone dosages in your non-cardiac arrest patient. In cardiac arrest patient, the first dose I use for a shockable rhythm is straight away 300 milligram followed by 150 milligram. In a cardiac arrest patient, the bolus dose is given. It is not given as a slow infusion. But in a root patient who is not into cardiac arrest, we give amiodarone as a slow infusion over 10 minutes, and we don't bolus it. So this is about the various bradycardia, tachycardia, the approach to COLS, BCLS, and CCLS. And now let's talk about these approaches or these algorithms into special population. Now, pediatric, I'm not going to go into the details of the algorithm, but certain important difference right from your scene safety point. If you are able to remember that, that will be a good way to remember your differences in the pediatric guidelines. Now it's a witness versus non-witness cardiac arrest in pediatric becomes very important. Again, if it's a witness cardiac arrest, you can call the team first if you are alone. If it's a non-witness cardiac arrest, what is recommended is that you give one cycle of CPR and then you go for inform someone or call someone for help. This is an important difference in the pediatric if you are alone. Assessment in infant, we do a tactile stimulation on foot, generally instead of shoulder. Pulse check in infants, again in the we do a brachial pulse in the mid arm because that is more easy to feel as compared to a carotid pulse in the infant where there is absolutely no neck or difficult to palpate. Now, threshold for initiating CPR in a pediatric is less than 60 beats per minute. You don't wait for an heart rate to completely go down. And in an infant or in a neonat, you start a positive pressure ventilation even if your heart rate is less than 600 per minute. This is an important difference. So if you remember along the steps, like you remember your adult guidelines, and at the same time in the adult guidelines, remember what are the important differences in the pediatric, it becomes easy to remember. CPR technique in pediatric patient, if it's a small baby, instead of using two hands, we can do a single hand technique. We can do two finger compression technique or chest encircling technique, depending upon how many people we have. Here you can see this is a chest encircling technique because there are two people. We can do chest encircling technique. This is very useful. If you are alone and doing it for infant, a two finger technique is something which is important. Ratio, again, if you are alone, we start with 30:2, but as soon as there are two compressor in pediatric, the ratio changes to 15:2 because that is very important for ventilation, or hypoxia is the major cause for cardiac arrest in pediatric cases as compared to adult. In neonate also the ratio changes. Again, the drugs, the gadget, the dosages change as per the body weight. In adult, the adrenaline dose is 1 milligram being given every 3 to 5 minutes. In pediatric, we dilute this adrenaline, that is the standard ampoule of adrenaline of 1:1000. We dilute it to 10 ml and then we give it 0.1 ml per kg. For example, if it was a 3 kg baby and I have diluted it 1:10, then I'll give 3 ml as a dose of epinephrine every 3 to 5 minutes. If it's a shockable rhythm, amiodarone is used in a dose of 5 milligram per kg. For joules, for pediatric defibrillation, the initial dose is 2 joules per kg. It is followed by 4 joules per kg into the next dosages as required for the patient. Again, in infants and neonates, we need to be careful about the ambient temperatures, the surrounding temperature. Monitoring devices have gained significant role. Airway devices, supraglottic devices have now gained significant role even in adult resuscitation as well as in pediatric and neonatal resuscitation. And the SpO2 targets, if we are monitoring, is not routinely 95 to 100%. Look at this preductal SpO2 after birth, and this becomes very important for all of us to follow to prevent hyperoxia related injuries during the CPR. Now coming to the pregnant patient. So in pregnancy, what is important is that 2 lives are at stake. So I'll just again highlight the differences between CPR in normal patient and CPR in pregnancy. First is the uterine position during CPR. What we do is a left lateral uterine tilt is given, and we are not tilting the bed as was advocated in the previous guideline because CPR will not happen properly. Second is, whenever possible, at least in pregnant patient, the vein should be secured above the diaphragm, that is in upper limb or neck or where, because the drugs will go easily rather than in lower limb where your gravid uterus will prevent the drugs to get to the heart. Airway, we all talk about airway in pregnancy. It's difficult airway. So wherever possible, airway should be provided by senior experienced provider. Of course, it goes without saying, without interrupting the chest compression. Secondly, in pregnancy, we should try and aim for an early airway intervention because hypoxia will ensure faster. Magnesium toxicity is a very important cause in pregnancy. So whenever it is there, this is the indication for calcium gluconate to be given. The dosage is 1 gram administered over 10 minutes rapidly. We talked about 5H and 5Ts or hit the target. In pregnancy, we need to additionally talk about A, B, C, D, E, F, GH causes. That is anesthetic complications, bleeding, cardiovascular, drug error or drugs like magnesium, thromboembolism, amniotic fluid embolism, fever, infective causes become very important. The 5H and 5Ts or the hit the target becomes important. And of course, the hypertensive disorder in pregnancy. This is another important thing to remember. Perimortem cesarean section. We all should be thorough with this. This is an established standard norm now. People have slowly started accepting this into the institutional practices. The perimortem cesarean section is something which can be asked even as a short note, and we all need to be thorough about it. The idea is, if it is not happening, if the patient has not achieved ROSC within 4 minutes, we need to straight away go for a perimortem cesarean section. It needs a significant amount of expertise from obstetric team as well as the anesthesia team or the intensivist team. It has to be done at the bedside. If your patient was in labor room, we don't take this patient to the operation theater. We do the perimortem cesarean section then and there itself. We don't emphasize too much on cleaning and draping. You can simply pour a povidone. We don't bother too much about hemostasis. We give an incision straightway till the uterus, preferably a vertical incision. The baby is taken out, and probably either baby's life can be survived, and simultaneously with the uterine autotransfusion, the gravid uterus coming down, this might help the maternal life also to be saved. Again, so these are the special populations. We can, if time permits, we'll talk about the hypothermia, drowning, and other scenarios as feasible. Now, last part of the talk today is about the updates or desirable to know things. So the importance to this topic is given because it's a leading cause of death. Many are potentially avoidable. All this has come significantly. The team dynamics part of this has come from the aviation faculty or the military faculty. And the thing which we talk about is the crisis resource management, especially the second year postgraduates who have good amount of time because they are not the final years completely burdened, and they are not the first years who are burdened with too much of clinical work. They are good time for them to read about crisis resource management. If you are able to answer this in your viva, it is actually a rewarding thing to look into. Then we look into the 2020 AHA guideline. Look at the recommendation. Only almost 33% of these recommendations are level, class 1 indication. And if you look at the level of evidence, almost 1% is level A, because you cannot have multiple randomized control trial in such a critical scenario. So this is again very important. This shows that when you are reading any journal, this is a paper, or when you are reading any guideline, you understand what the guidelines are all about, and you don't like blindly understand that okay, this is mentioned in the guidelines. We need to understand what are the recommendations. So if you are telling a guideline to an examiner, and at the same time if you are able to tell, sir, this is actually class 1A recommendation, that actually adds to the weightage of the viva which you are giving. Then has it stuck? Okay. So this is again very important. If possible, go to this WHO emergency care system framework guideline. So all this talks about scene, transport, and facility, that what actions has to be done during the scene, what action has to be done at the transport, and once you arrive at the facility, what is to be done. This pretty much applies for the CPR also. Monitoring updates, real-time audio and visual feedback devices are there. If you have a EtCO2 and invasive blood pressure which is already attached to the patient, this becomes very important. EtCO2 of less than 10 millimeters of mercury throughout your CPR indicates either your technique is not good, or probably the patient's outcome is going to be poor. Secondly, if you are having an invasive blood pressure, say patient was in ICU or in operation theater, you can target a diastolic blood pressure. And if you have a diastolic blood pressure adequately, then you can say, or you can increase the amount of your chest compression or quality of chest compression. This is a device which is now commercially available, not very costly at this stage. This is an accelerometer device. If you can pay, this comes with most of the ready-made defibrillator. You can press it, you can keep it on the patient's chest, and you can give CPR over this thing, and it will actually give you audio feedback that your chest compressions are becoming fast, are becoming slow, your depth is less or depth is right, and this is something which will improve your quality of chest compression significantly. Then additional thing you need to know, the importance of why to decrease the peri amount of pauses or shock. So you see, this is the perfusion pressure which is required for organ, including the coronary procedure. The moment you halt the compression, it abruptly goes down to 0, and then it takes at least 8 to 10 compressions to bring that back the perfusion pressure to normal. And your chances of defibrillation are more successful when you have a good perfusion, rather than when you are doing it in a phase when you are not giving a perfusion. The clinical application of this thing is, when your defibrillator is charging, you should continue to do the chest compression. If you do the chest compression, your energies will be supplied to the myocardium, and the defibrillation which you will be giving, there are more chances that the defibrillation will be successful. Now, another thing is the quality method. People might ask you, what is the CPR fraction and perishock pauses? We just talked about that. The CPR fraction is basically the amount of chest compression which has been done overall in the cycle of CPR. The recommended is at least 60%. What I mean to say is, say I was doing a chest compression, suddenly somebody came and they said, let me intubate, your hands came out of chest compression, now your time has decreased. Somebody came and say, I am finding it difficult to understand what is the cause, let me do an echo, and your hands have come out of chest compression. So this CPR fraction is decreasing. The total time which should have been devoted to CPR is decreasing. So what they require is at least 60% of the overall cycle your CPR should be going, and desired is somewhere around 70 to 80%, depending upon the phase which you are doing onto CPR. We all need to know about mechanical chest compression device. Again, these are desirable to know. I have not gone into details of those things, but you have something like what we call as the autopulse device or the Lucas device. They are either a simple spring-based device, or they are a circumferential compression devices. The importance of them is, if you are transporting a patient, if you are doing an ECMO, if you are doing some trauma control patient to this patient, or if you are doing a prolonged CPR measures, these are very helpful. They have not found a class 1 recommendation, and it is not that if you don't have these devices, your CPR will be ineffective. Again, very important to know. Now, defibrillation, we all know, we talk about 120 joule, 150 joule, 200 joule. Most of the current defibrillators which are available in all the institutes are biphasic. But there was a time when monophasic defibrillators were available, and we need to understand the difference between monophasic and biphasic. The important difference between monophasic and biphasic is, in monophasic, the current transfers only from one side. Okay, so then you will need more amount of current. In biphasic, what will happen is, during the initial period, the current will go from this lead to to this lead, and rapidly within the same time, the current will go from this, it will reverse the polarity of the pads or the defibrillator paddles, and the current will go on to the other side. Thus, within the same amount of joule, you will have more effectiveness. So monophasic will need a higher joules, biphasic will need a lesser joule. A lesser joule means more effectiveness and decreased amount of injury to the myocardium. I'll not go into the details, but read if possible what are the various phases of biphasic defibrillator, what is the rectilinear and truncated exponential waveforms. Again, a double sequential defibrillation for refractory defibrillation. This is something which has been coming into the some sort of studies. What they say is initial 2 to 3 defibrillations if you are doing and they are not successful, and even after 2 to 3 defibrillations, if your rhythm continues to be VF VT, you can do 2 defibrillations back to back. So one you can put an anteroposterior aspect, and second you can put on the under the right clavicle and left pad, and you can do 2 defibrillation. But again, this is not, the data is controversial, and this is still not found a clear cut way into the guideline, but it is on the individual decision. We already talked about the supraglottic devices update. Nowadays it is recommended that wherever possible, bag and mask ventilation should be done. If possible, supraglottic devices should be done. One should not rush into intubation unless and until the clinical condition demands. It should be done by an experienced person, and the intubation should not cause your interruption in chest compression and should be preferably done within less than 10 to 15 seconds. Now, how do you give drugs? IV is the most preferred one, isn't it? But if you are not able to do an IV, intraosseous is very much acceptable. In the older guideline, it was IV, intraosseous, or endotracheal route. Nowadays, it is IV or intraosseous. If not possible, then endotracheal route, isn't it? Intraosseous is very easy to establish. One can establish an intraosseous access within 30 seconds at times in this patient where IV might take more time. Vasopressin and corticosteroids. You might have heard about the studies where people are giving vasopressin and corticosteroids. Again, not a clear-cut advantage. Still not found its place into the guidelines. Calcium, no routine role, especially in a non-condition. If you are suspecting some condition, say hyperkalemia, magnesium toxicity, yes, you can give calcium. Magnesium, torsades deep point is if you are suspecting, you can use magnesium. No routine role of sodium bicarbonate. Only if you are suspecting a significant amount of acidosis, then you are supposed to use a sodium bicarbonate. Coming to few important point of care ultrasonography in CPR is coming, especially if you want to detect reversible causes like tension pneumothorax, tamponade, or embolism. But the important thing is it should be done by a senior person because the findings will not be easy to interpret. Secondly, it should not cause any interruption in your chest compression. ECMO CPR has gained significant amount of weightage over a period of time. ECMO gained a lot of traction during the COVID-19, but the indication, again, it's a cost, very resourceful settings are required for ECMO CPR, but you should be able to know, especially if you are looking at a reversible cause, if especially had a big pulmonary embolism, if your patient say had a good cardiac function but had developed a sudden cardiac acute coronary syndrome, probably these are the good cases. And if you are able to have that much amount of expertise where all of this can be done rapidly and throughout your resuscitation was good, then you can see that Lucas device being used here during the use of ECMO CPR. Now, the last slide about the good team dynamics. This is something which will be asked to everyone. So we talk about the team leader, we talk about the airway, we talk about compressor, we talk about a person with monitor defibrillator, somebody to give the medication, and ultimately a person to record this thing. If you have less than 6%, some of the roles will have to be switched. The minimum people required for an advanced ACLS or CCLS is at least 3. If it is less than 3, it is almost a BCLS because then the focus will be on compression, defibrillation, and airway, isn't it? So that becomes very important. Now, what are good team dynamics? Your role should be clearly assigned. The team leader should know everybody's strength and weaknesses. There should be clear instruction. बहुत बार हम लोग instruction कैसे देते हैं? Give some adrenaline. give some atropine. Now, this is not a clear instruction. Give 1 milligram IV adrenaline followed by 20 ml of normal saline. This is a clear instruction, isn't it? Now, closed loop communication, again, very important. If I have given this to a nurse order, you might be doing CPR at a places where your team is different. You might be called into an orthopedic ward where the team is completely different. So if your team doesn't understand closed loop communication, you might give a wrong order. I had said 1 milligram adrenaline, the sister didn't listen. She might have said, okay, probably sir has asked for adenosine, and she might give an adenosine. So your closed loop communication become very important. There should be no crosstalk. Airway should not talk with compressor, or like they should not dictate each other. Ki, oh, you are not doing it properly. I think the team leader is not doing. Whatever constructive criticism has to be done, everything has to be directed at team leader so that he can then give a proper instructions to everyone. And at the end of the scenario, a proper debriefing should be held. Now coming to the last part, that is the, if you have achieved a return of spontaneous circulation, your approach remains airway, breathing, and circulation. If you remember the initial slide, if the patient is in cardiac arrest, it is CAB. Now the patient has come back from cardiac arrest. The patient's approach has to be airway, breathing, circulation, with maintenance of airway, with maintenance of breathing saturation targets of 94% and around, and circulation, maintenance of pulse and blood pressure. Now, if your patient is unconscious, there might be a possibility that your patient had suffered a hypoxic brain injury, but we are not yet sure. So how do we decide on that? We talk about targeted temperature management, but over a period of time, significant trials have changed. So the current recommendation is, the important principle is, avoid fever in the initial 48 to 72 hours. That is the most important thing. In severe brain injury, probably you can still consider 33 to 36 degrees of targeted temperature, and how we do that is a completely different topic, and we are not going to discuss it, but this is something very important. And if your patient had an cardiac arrest, then probably the most common reason would be an acute coronary syndrome, and when to do a angiography becomes very important. If you see an ECG ST elevation, probably we need to do it in an early stage. If you don't see an ECG elevation, but the signs and symptoms are suggestive of ischemia, probably it's an individual call decision whether to do a cardiac arrest angiography. It's not a contraindication that post cardiac arrest patient, till he's not awake, I'll not do a angiography or angioplasty. Lastly, we talk about neuroprognostication. If the patient was unresponsive, we cannot say with full confidence at an early stage that my patient will not come out of this thing. So it has to be a combination of clinical management, imaging, electrophysiology, and serum biomarkers. Again, a bit up there, but the prognostication has to occur after 72 hours of targeted temperature management, and once the rewarming has been completed, not early. So that completes my talk for this thing. So there are some other protocols which you will remember: the null please score or the crest score, flatline protocol, and be ready for some googlies in the examinations. Thank you.
Thank you, Dr. Dheeraj. And first of all, you must go and have a little glass of water. This has been such a wonderful class. I mean, I think I'll take the liberty to thank you on behalf of all the students, because this will be a very, very useful class for them just before their exams, their MD, PG practical exams, and DNB exams. Dr. Dipanita, we have a few questions, but if Dr. Dheeraj, yeah, Dr. Dheeraj, are we planning on some demonstration of skill stations also?
Sir, for the paucity of time, we have done a ready-made skill lab. We are doing it from the skill lab. So we have done a video. So if it is okay, we can play the video, sir, because I understand we are running short of time. As you say, sir, if you want, we can demonstrate also, sir.
As you wish. As
Nishant, we will
Keshav
be,
and Dr. Suhas, are you ready? So if
Nishant,
possible,
we will be winding up at 8:15.
8:15.
Yeah.
Then I think we can show the skills, Nishant. We have the strategies.
Right. Dr. Dheeraj and team MGIMS, if you want to demonstrate your skills in the skill lab, we can go ahead. That will be useful, I feel.
Sure, sir. We'll do that, sir.
Is that okay, madam?
Yes. Please go ahead with showing the skills. That's very important.
Yes, and something innovative also.
By the time they are getting ready, you can just attend to the chat box questions, if any.
Sure, sir.
Dr.
So,
Dipani.
Yes, sir.
meantime, can you make it ready? Can you make it horizontal?
So we have three questions, two from Dr. Muthukumar Rajagopalan. So he has asked, the first question is, do we have sotalol and procainamide in India? And if so, he would like to know the dosage. And the second is, if there is no intraosseous cannula, so how do we establish the route?
So, I have not used procainamide and sotalol in Indian scenarios. I have never used that thing, but sotalol I believe is available probably in India. Second is, what is perishock pause?
Yes, sir. What is perishock pause?
Am I audible?
That is
Yes. Yes.
So the second question was, what is perishock pause? So
Yes.
perishock pause is basically the pause which is given between the time when the defibrillation is charging and actual defibrillation. So for example, let's go to the scenario that I have seen my patient has a ventricular fibrillation or ventricular tachycardia. I decide that it's a shockable rhythm and I charge my defibrillator. But this charging will take certain time, say 3 to 5 seconds, 2 to 3 seconds, depending upon the machine. During that time, actually, I should not pause and wait it out. During that time, I should actually start doing chest compression. Those 8, 10, 12 compression, when your defibrillator is charging, will decrease the perishock pause. And the advantage is it will give more amount of ATPs and energy oxygen to the myocardium, and your chances of defibrillation, which is happening after this chest compression, will be very, very successful. So two scenarios, I waited out for my defibrillator machine to charge and I give my defibrillation, chances of successful defibrillation decreases. If I continue to compress my chest when my defibrillation is charging, my defibrillation success becomes very strong. So this is the perishock pause which I should decrease. Can we give, shall I go to next question?
Skills.
Yes,
Start showing
yes.
the skills.
Can we give adrenaline in refractory cases of shockable rhythm after say about 15 to 20 minutes of CPR? So yeah, basically adrenaline, again, it's a very straightforward drug, and there is no actually upper limit to what amount of drug you can give. And even for that matter, what is the upper limit or when should I terminate my CPR? Again, is the individual clinical decision. Say for example, I have an old aged patient, 75-year patient, diabetic, hypertensive, long bedridden, and he developed a bed sore, went into sepsis, septic shock. There is a clear-cut bedridden patient. Probably I'll not go for a significant amount of resuscitation for this patient. But imagine a patient I have in an operation theater scenario. I was giving a supraclavicular block to this patient. I developed a local anesthesia toxicity. I'll go to the limits of doing resuscitation, extended period of time for this patient, and then during this extended period of time, I'll continue to give a CPR. CPR, again, the adrenaline dose is very clear. 1 milligram adrenaline every 3 to 5 minutes. Actually, when we are doing it in a skill, we are able to demonstrate it very nicely. Basically, it means that 1 milligram of adrenaline every alternate cycle of CPR has to be given in a simple way. Suppose this was my first cycle, I gave adrenaline. Second cycle, I don't give adrenaline. Third cycle, I give adrenaline. Fourth cycle, I don't give adrenaline. So as a team leader, if I'm standing at the foot end, my job is very straightforward. I start with my cycle. My first person I remember is, I'll talk to the person at chest compression, I'll give him the instruction. Next person, I'll talk to airway, I'll tell him the instruction, give him the instruction. Third person, I'll talk to the defibrillation. Once his job is done, then I'll go to the drug person. Drug person, there are two important during the cycle. One is one drug to be given and one drug to be anticipated and prepared for the next cycle. As simple as that. So adrenaline can be given in refractory cases of shockable rhythm, and even in normal cases of shockable rhythm also, adrenaline has to be given. There is no question about that. Shall we are ready with the demonstration. Shall we demonstrate it?
Yes, sir.
Or shall we finish the question? If we don't have the cannula for intraosseous route, how do we do it?
No, you please show the skills.
Okay, ma'am.
Show the skills.
Okay. So I think we are visible here currently. Is our team visible now?
Yes, your team is visible. What I request is that everybody could pin your screen on their screens. Like if you click on the three dots and right click, there is a pin. If you can pin it, then the whole screen becomes your screen. You may start, Dr. Dheeraj.
Okay. So we have our two postgraduates, Dr. Keshav and Dr. Suhas, and I'll give them a BCLS scenario as routine. Imagine you two gentlemen are traveling by flight to somewhere. You're waiting for boarding to happen, and say next to you was sitting a 65-year-old gentleman, and you see him suddenly he has collapsed in front of you. So now, how will you approach? Imagine this is the person. I am your instructor. I'll create this scenario, and you keep on telling me what is happening. Okay, so we have these two people who are doing this BCLS scenario. Let's see. There's slight difficulty in the video, but they are doing it from the opposite end. I hope it is visible. Okay.
Checking the scene safety.
Can you tell it loudly so that they'll be able to say it?
Checking the scene safety.
Yeah, thank you. Okay.
Then we have made sure that the scene is safe, and we have to check for the response of the patient. Hello, are you okay?
He is not
Are you
responding,
okay?
Dr. Keshav.
Then we have to call for help. Sir.
So,
Dr. Suhas, could you call an ambulance and get the AED and Bagan was available or not?
So just a minute, we'll pause here. So can you see they have done three important steps. First, they did a scene safety. Then they did a complete check for response for this patient. He tapped on both the shoulders. He called out the name of the patient, and simultaneously he was looking at the patient's response. When I as an instructor said that the patient is not responding, he then instructed his fellow person or fellow colleague or whoever is present there that to do three important things: get an ambulance or whatever is required. Secondly, see if the AED is available nearby. And third thing is, if there is ambu bag or something, if it's a code blue in hospital, you can ask for the crash card. So now let's take it from here that you have completed the this process. Now let's go to the pulse and respiration checking part of it. So now imagining that the Dr. Suhas has gone to bring the AED and ambu bag. Currently, Dr. Keshav is alone with the patient. Now he's doing a pulse and respiration check. How will you do it? Do it.
1001, 1002, 1003, 1004, 1005, 1006, 1007.
No pulse, no respiration, Dr. Keshav.
I think he made the cardiac arrest, so straight away starting with CPR.
Okay, just wait one more minute here. Now, if you see, he has done a pulse check, he has done a respiration check. He has not counted the rate of pulse, he has not counted the rate of respiration. Simply yes or no. And the way he was looking, he was tangentially looking at the breathing while his hand or the fingers will palpating the pulse. So two very important thing, isn't it? And then he's identified that the patient is in cardiac arrest, and now he's proceeding for the chest compressions. So I am unable to pull it further, but if you will be able to see the mannequin, start doing it. Count it loudly.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 26, 27, 28, 29, 30. 1, 2.
That's excellent. Just wait for a minute. Now you see the hand position. He identified the sternum. He put two fingers above that thing. His elbows were straight, and he did a 30 count properly. After that 30 count, he didn't wait for next thing to happen because he didn't wanted to give mouth-to-mouth breathing. So he continued simply with the chest compression cycle. Now I will be instructing as an instructor because I'm satisfied with the way I have evaluated Keshav. Now I'll be instructing Dr. Suhas to bring the AED and the ambu bag, which is available in the airport, while Dr. Keshav continue to do the CPR. Okay. Okay. So what you can do is right now is imagine I am the AED, and you can simply continue to do this. Don't on because we have paucity of time. Just connect it. Connect it. Do it in an artificial way. Okay. Attach the AEDs as shown in the pad. Attach the AEDs as shown in the pads. Press the pads firmly. Press the pads firmly. Analyzing rhythm. Do not touch the patient. Do not touch the patient. Analyzing the rhythm. Shock advised. Shock advised. Shock advised. Charging, 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 charging. Charge ready. Charge ready. Shock given.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, breathe out, breathe in.
Excellent. Shall we wait? So what has happened here is from the second scenario, he brought the AED as well as the AMBU bag, but he identified that the AED has a predominance over the AMBU bag at this stage. So he attached the AED pads. But while attaching the AED pads, as you can see, he didn't stop, Dr. Keshav didn't stop the chest compression. Can you just keep your hand there? So he continued to do chest compression, whereas Dr. Suhas, he attached the pads along the hand. So in case if you have monitor, same thing, you will attach the ECG leads and do that thing. So when the AED prompted or the manual defibrillator prompted that it was a shockable rhythm, that time they continued to do the chest compression and they didn't stop. Only when the charging was completely ready, then they shocked it. This is what the perishock is. Just to explain it again, suppose I am telling you, do not touch the patient, analyzing rhythm. So this is the time when you should not touch the patient. Then if I am saying shock required, charging, continue CPR, charging. So during charging, he is actually continuing the chest compression. And once the charge is ready, then everybody clear and then do the CPR. Last important step, which has been in the older guideline, is immediately after the defibrillation, we don't stop to check the rhythm or to see the pulse or what is happening on the monitor. Straight away after defibrillation, we start the next cycle of CPR.
Excellent, Dr. Dheeraj. Dr. Dipanita, do we have any further questions?
Intraosseous, sir,
Sir, one question. Yes, intraosseous line was there.
So intraosseous cannulas are commercially available, but I agree they are costly, and especially with the intraosseous gun which is available there. And what we need to see is, if you don't have that thing, Jamshedi needle, which is very commonly available, cheap, can be utilized. In a very rare scenario, you can use a hypodermic needle, but the hypodermic needle problem is initially it will bend. So what they say is probably a 2 hypodermic needle initially to go up to skin and subcutaneous tissue and periosteum, and then to give it the second needle so that it goes in straight away in. It's very easy to do, especially if you have a proper needle with this intraosseous needle.
Dr. Dipanita, unmute yourself. Is there any other question?
Yes, sir. There was one more question. So it was asked that can we give adrenaline in refractory cases of shockable rhythm after 15 to 20 minutes?
Yes, we can give.
Okay, sir. Thank you. So that was all.
Very nice. So I think, Dr. Dheeraj, is there anything else that we have?
There were a couple of protocols, but I had decided to skip it. So those flatline protocols, SS protocol, everybody who is doing in anesthesia department, they'll be doing it. So probably we have a CCLS video. We'll send it to you, sir, in case if it is required.
Okay, but yeah, this has been such a useful class that when it will be really useful for all the postgraduates just before their exams. They'll be watched by many people, I'm sure. Dr. Madhuri ma'am, is there anything else that you want to add?
No, I think Dheeraj has really covered everything. It was an extremely vibrant lecture, and he has told so many newer aspects of CPR. That was very nice. And in the DNB exams, we have this separate table on resuscitation. And even for MD, for many universities, you have a separate table on resuscitation where the examiner will ask you all questions related to CPR and will make you demonstrate the skills, and the examiner will observe and then give the marks. So this class was based basically for so that the student can face this Viva table. Yeah, I think that's it. He has really covered it in a very beautiful way. Thank you, Dheeraj.
Yes.
We from MGMS, thank you all for giving us this opportunity to be a part of this ISA National Online Program, sir.
Over to you, Sukhvinder Bajwa, sir.
डॉक्टर धीरज ने आज इतना अच्छा पढ़ा दिया, मतलब कुछ कहने के लिए शब्द नहीं है. डॉक्टर धीरज, it was a wonderful class. Ideally, you know what I was feeling. You had to rush because of the request by me to finish it in time. Otherwise, it could have been done in a very slow and comprehensive manner. Could have been divided into 2 parts. What I was thinking during the middle of the class, it should have been in 2 parts. But I think we will have it. Some revision part of it also from your team after 1 month, maybe after the conference. We will have some revision parts, some problematic parts in the CPR, the different scenarios in the pregnant patient, the special population, and all those conditions we can discuss. I think we will be giving the opportunity to your team only. Your students have done very well, ma'am. I think everything was good about it, and we will be continuing this part in the part 2. I think you will be agreeing to that part also.
Thank you, sir.
Okay, I think that's good because today really the paucity of time that tomorrow we have to lock the website for the elections also. So that's why we are feeling. I don't want to ask anybody to give suggestion today because we have another meeting with all the candidates, the president, secretary, myself, and then CEO and election officers. So the Zoom platform is not free. Otherwise, we could have continued for the class. So next, I think also Dr. Srekha Madam has told peripartum CPR learning. Yeah, we will. Dr. Dheeraj to take a note of it. The peripartum, the neonates, the infants, the geriatric, the special populations. So we will be covering within after the conference, we will have that class. Dr. Madhuri.
Yes, sir. Yes, sir. I think that's a very good idea. Definitely.
Okay, so we will definitely do it. And in that part also, we will be able to cover many questions here.
Yes, yes.
So before doing any further thing, I want to. My screen is visible?
Yes, sir.
Yeah. So first of all, we like to felicitate our esteemed teachers today. Sucheta Tidke ma'am, we are really thankful that you have spared your precious time. See, I can see it more precisely. The PG students are standing right behind you. That means the way you have taught them how to remain in a team. That's what the essence of a CPR is, how to be a part of a good team in CPR. So really nice that the PG students are standing right behind you. So we are very thankful to you, ma'am, for providing us this platform to learn from you people. Dr. Dheeraj, we are extremely thankful to you. So we have found another gem who can conduct these classes at a national level regularly or workshops or other parts. So we will be involving you into the coming months and all the future academic programs where the cessation skills have to be taught. So we will be involving you there also. First of all, thank you for this class.
Thank you, sir.
And Dr. Suhas, you have done a wonderful job. And I know you didn't have that much time to showcase other skills of yours along with Dr. Kesava. Also, because you both were doing good job, but due to lack of time, you had to show in a very limited manner. But I think the next class, you people will be there and you will be showcasing your skills again in the further teaching. And Dr. Dipaneta, you made a good debut. So this is I am also proud of it that Dipanita has done a wonderful job and she will be doing good job in the coming days also. So, and I don't want to give Nishanda or Dr. Madhuri a certificate because they are very senior teachers. Doesn't look nice to give them certificates every time. So that's all from my side. Any 1 or 2 minute suggestion anybody from want to give? We can take. I'm talking about in the next month class, maybe in the after the conference we will have class. Anybody wants to add? Dr. Surekha madam has told about the peripartum. Anybody wants to add something different to that? Surekha ma'am, you just take 1 minute. I'm just enabling everyone. Just wait. Yeah, you can unmute yourself, ma'am. Unmute yourself and tell.
Yes, sir. I will request actually always in the conference also. I am raising the issue of peripartum cesarean section decision that is not happening actually, and
Okay, ma'am.
yeah, it's very important even to save the even single child, any single neonate. So that is a big issue, sir. Nobody is actually risking in that, and at institute level also decision doesn't happen many times. But we have tried in BJ Medical College 2 times that by giving a CPR for almost 1 hour, we have done that cesarean, saved the baby, and then the thing was over. But that decision is critical in those heart disease cases or some complicated young women, pregnant ladies coming. And again, user accepted that geriatric CPR, yes, must has to be discussed because it has got different aspects during the management of CPR. It is not only a rest.
Yeah. Definitely,
Yes,
ma'am.
thank you very much, sir.
Your advice is well taken regarding the perimortem cesarean section and research station. It was discussed in my last CME at Kolhapur also, and we are going to discuss in detail whenever we get a chance to
Yes.
fully focus on that part.
Yes,
So
sir.
that
People
will definitely be discussed.
yes, sir. Seniors should be motivated to indulge, to take this decision actually. Otherwise, just because mother is serious and is left into the ICU just like that, and nobody takes the
Definitely,
decision.
ma'am. There were certain issues related to that, the legal issues,
Yes,
the
yes,
decision
yes, sir.
making,
Yes, sir. Yes, sir.
the
Yes.
decision making, the
But
seniors, how much confident they are
yes,
doing in that.
yes,
That is
yes, sir.
definitely on the
Yes, sir.
cards. It is on the cards, ma'am. We will
Yes,
definitely
sir.
discuss in that next class. Dr.
Yes.
Dheeraj, we will be touching upon the perimortem cesarean delivery and resuscitation also.
Thank you,
Okay.
sir.
Okay, ma'am. Anybody else? 2 minutes. 2 minutes left. So I think we have done for the day today. It was a beautiful class, wonderful class. So it is a part 1. That is assigned from the headquarters, part 1. So part 2 also, Dr. Dheeraj and team will be doing part 2 exactly almost after, I think, 35 to 40 days. So we will be doing that class. Fine, Dr. Dheeraj? Okay. So I think, thank you, Dr. Nishan, Dr. Madhuri, and for holding the fort. And we will be having a very good next class. I will be discussing with Dr. Madhuri. And then we'll coming back to you.
Hello, sir.
Dr. Mohan
Good
Pathak,
evening.
sir, you want to say something?
Yes, sir. In cardiac
1 minute,
cath lab, there is
only
a
1 minute,
condition.
sir. 1 minute, please. Carry on.
In cardiac cath lab, conditions are ideal. There is already cardiac cath. Everything is available. That time, cardiac resuscitation is easier, I think. So, and it can be continued during the. We can continue the cardiac cath also, angiography also, and stenting everything. So that time, it is the best condition to resuscitate it in case cardiac cath happens, cardiac arrest happens. I wanted to tell that. That's
Yeah, thank you. That's
Yeah.
a very good point. And definitely it is more salvageable and more prognostic. Prognostic factors
Yes.
are much better in that scenario.
Drugs can be directly given through the wider cannulas.
Definitely. A similar thing you can be saying when the cardiac arrest occurs during surgery, when the abdomen is open, the surgeon can easily touch the heart, and that's very easy to give the cardiac massage by manually also at that time. So
Yes.
these are the very good conditions where we can easily save the patients.
Really tackle the things. Thank
So,
you, sir.
Okay. And thank you, everyone. And we will be seeing you next Monday. And the next 1 week will be full of elections, election materials, and election matters. By that time, I think we will take off a little time away from the academics. So, thank you, everyone. And it's time to say good night, goodbye. And we always end by saying, long live ISA.